Hey everyone. Today, we're going to connect the dots on a clinical picture you'll see time and time again. A patient with a scarred-up liver and a belly full of fluid. We're going to trace this whole problem from the microscopic level, right inside the liver, all the way to the pretty serious complications that can come from all that fluid buildup.
All right, so here's our roadmap. First, we're going to tackle the root of it all, what we're calling the pressure problem. Then we'll see exactly how that pressure creates a massive fluid issue. After that, we'll get into the nitty-gritty of diagnosing the fluid and, of course, how to manage it. And we'll wrap up with a really dangerous complication you have to be on the lookout for, a nasty infection.
So let's start at the very beginning, with the fundamental why. Because everything else we're going to talk about today, well, it all starts with a simple mechanical issue, a pressure problem that originates deep inside the liver.
This is really the million-dollar question, isn't it? How on earth does a problem in one single organ, the liver, cause such a dramatic, obvious sign like a fluid-filled abdomen? Let's break it down step by step.
Okay, first thing to get straight, cirrhosis isn't just one disease. Think of it as the end of the road for a whole bunch of things that can injure the liver long-term, like alcohol or viral hepatitis. And this process doesn't just leave a few scars. It totally remodels the liver's entire architecture, turning what was once soft, functional tissue into a stiff, lumpy, dysfunctional mess. So picture the portal vein as a major highway, carrying all the blood from your gut to the liver for processing. Now, imagine that cirrhotic liver, full of stiff scar tissue. It's like a giant dam has been built right across that highway. It physically resists blood flow, causing a massive traffic jam and a dangerous backup of pressure. And that is the pressure problem that's at the heart of everything. So you've got this massive pressure backup in the veins leading to the liver, but how does that problem actually escape the liver and show up as a swollen belly? Well, that pressure doesn't just stay put. It kicks off a whole cascade of events that leads directly to that fluid buildup.
And this brings us to what you actually see at the bedside. Ascites. That's the medical term for all that fluid in the abdomen. Honestly, when you see a patient with new-onset ascites, your mind should immediately jump to portal hypertension. It's the most common cause by far.
What's happening here is really a classic two-hit mechanism. First, that intense pressure in the veins literally squeezes plasma fluid out of the blood vessels and into the abdominal cavity. Then, as a second hit, the body gets confused. It senses this fluid shift as low blood volume and freaks out, triggering the kidneys to hold on to salt and water. This just creates a vicious cycle, pouring even more fluid into a system that's already overflowing.
Okay, so we see the swollen belly, and we're thinking it's ascites from liver disease. But how do we prove it? We can't just guess. We need a definitive answer, and the best way to get that is by analyzing the fluid itself.
This is where we perform a diagnostic paracentesis. We tap the fluid. It's a key procedure that lets us both confirm there's ascites and, more importantly, figure out what's causing it. And from that fluid sample, the single most important calculation we're going to make is something called the SAG.
And here it is, this number, 1.1 grams per deciliter. You need to burn this number into your brain. This is the critical cutoff value for what's called the serum ascites albumin gradient, or SAG. It's what makes sense of everything.
It's actually a really simple calculation. You just take the albumin level from the patient's blood and subtract the albumin level from the ascitic fluid. If that difference, that gradient, is 1.1 or higher, you can be very confident the ascites is caused by portal hypertension. If it's low, well, that points you in a totally different direction towards things like peritoneal cancer or an infection. It's an incredibly elegant and powerful diagnostic tool.
All right, so we've used the SAG, we've confirmed the ascites is from portal hypertension, so the next logical question is, what are we going to do about it? How do we get this fluid out? And, just as importantly, keep it from coming right back?
The management strategy is really a stepwise ladder. You always start with the simplest, least invasive thing, which is strict sodium restriction. You have to remember, where salt goes, water follows. If that's not cutting it, we move up to step 2, diuretics. And for patients who have really tense, uncomfortable ascites or just aren't responding to the meds, we can go to step 3 and manually drain liters of the fluid off with a large volume paracentesis.
Now, when it comes to diuretics, the specific choice here is absolutely critical. You can't just use any diuretic. The cornerstone of therapy is spironolactone. Why? Because cirrhosis causes the body to crank out a hormone called aldosterone, which makes the kidneys hold on to sodium like crazy. Spironolactone directly blocks that effect. We often add furosemide to give it a boost, but spironolactone is the real key player here because it targets the root hormonal problem.
So we have a plan to manage all this fluid. That's great. But we can never ever let our guard down because this giant pool of stagnant fluid sitting in the abdomen is basically the perfect breeding ground for a really dangerous, life-threatening complication.
You should never assume that acidic fluid is sterile. It's basically a warm, nutrient-rich broth, and it's all too easy for bacteria from the gut to sneak across the intestinal wall and set up shop, seeding a really serious infection.
And that infection has a name, spontaneous bacterial peritonitis, or SBP. The word spontaneous is key here. It means the infection just happens, without an obvious source like a ruptured appendix. Any patient you have with cirrhosis and ascites who suddenly develops a fever, belly pain, or confusion, you have to immediately think about SBP.
So how do you diagnose it? It all comes from that fluid sample you took. If the absolute neutrophil count is 250 or more, that's SBP. You don't wait for cultures to come back, you start broad-spectrum antibiotics right away. And here's a crucial point. You also give intravenous albumin. This has been shown to protect the kidneys and dramatically improve survival.
And this brings us right back to the big picture. All these things we've talked about, restricting salt, diuretics, draining fluid, giving antibiotics, they're all absolutely essential, life-saving treatments, but they're only treating the consequences. They're all about managing the flood, not fixing the broken dam. This leaves us with the ultimate question. How do you actually fix the underlying pressure problem? Well, the answer lies in treating the cirrhosis itself, which, for many of these patients, ultimately means one thing: a liver transplant.